6 months later, and B, this would have become such a successful platform. And there have been many webinars on topics that have included frequently just expert presentations for 20 minutes or so. And in thinking about what might be something interesting to try, and this is the first experiment, and some of this may just fall flat, but is to try to replicate what we've done at many institutions that I learned from Dr. Castaneda and others, which was called Professor Rounds, where you would sit around and talk about a topic and go from point A to point B and call on your colleagues and friends at rounds. And frequently it goes in directions that you don't expect. We decided today to talk about transposition. This was totally a selfish topic on my own part, and I'll explain to you why in just a second. And I had the opportunity to call some people to see if they would be able to just join in on the fly without fancy preparation, without the best pictures they could possibly show. And I'm really happy that Damien Kenny is here with us. On my screen, he's in the upper right-hand corner. Hopefully Ziad Ajazi will be joining us as well, representing cardiac catheterization. My good friend Paul Kekia from Texas Children's Hospital and Cardiac Intensive Care Unit, and my new colleague and Surgeon-in-Chief at Children's National, Yves Dudekem, who I have no idea what he's going to say. We've only been working together for about 2 weeks, so I'm going to learn as much as I think everybody else here is. I'm going to go to sharing my screen here. Let me know. And then I'll do the obligate, can you see my slides? Can you see my slides?
Yes.
Yes.
Yes, okay, good. I do want to direct people to the Congenital Heart Academy YouTube website. We now have about 5,200 subscribers in just a few months. We thought transposition would be an interesting topic to discuss. As you can see, there's already been 7,400 views of our last transposition update. So we're getting close. We're getting pretty close to some of the cat videos that are on YouTube. That last piece that Sasha played was a charity piece that we did with the Baby Blue Sound Collective from my YouTube channel as well, if anyone is interested in learning about that. So what I'm going to start with anyway, as we move forward with this, is an introduction, talk a little bit about the series, find out about everyone in the audience. We're going to talk about transposition immediately after birth, imagining we're at the bedside of a little baby who was just born. Then we're going to talk about immediately after surgery. And then we're going to talk about the next 40 to 70 years. It's quite ambitious, but we'll see how it goes. So the first thing I'd like you all to do is to find another browser, either on your telephone or an iPad, laptop, desktop, whatever. And please type in ahaslides.com/TGA CHA for Congenital Heart Academy. So AHA slides, slides.com, TGA CHA.com. I think I'm going to now see if I am able to switch to a different share. I should be able to. So just so everybody gets comfortable with this platform, this is a test. So first, it looks like we have just a small number of the participants. So it'd be very helpful now. If people can find another browser, there will be opportunities. You don't need to go for each different question right now. We try to do one at a time. But if you could look at this and identify what is a bird. And I'll give you all a little bit more time before we move to the next question. Again, the URL to use is ahaslides.com/TGA CHA. I'm very happy to see that 11 people so far have recognized, now 12, Charlie Parker. This is Bird. Charlie Parker, of course, is the king of bebop, alto sax player. On the right is Jeff Bird, so those 8 of you are correct. In green there in the middle is Larry Bird. I figured Damien must have gotten that right. And most people are getting the eagle. So this is very a US-centric slide. I'm going to move to the next one now. So if those of you are on your phone, again, if you could log on to this, it'll be fun as we move forward. The next question that I have for you is, how did you learn about the webinar? please click all that apply so we can learn how we can further get the information out for these new series that we have. All right, we have, thank you. We have about half of the audience is now logged on to another browser. And we're getting, Grace, I would guess this is pretty similar to what we're seeing in all the other webinars that we've been doing, that the majority, at least right now, is still by email. And maybe what we'll do is we can poll the audience at another time to find out what we can do, how they would like to hear about it, or what might be better for them. Okay. What best describes your daily practice? This is helpful for us to figure out how to tailor these types of questions in terms of who our audience is. And I'll tell you, having done a few of these webinars, it's really helpful. You know, when you're used to giving in-person presentations, you can get an idea of who you've put to sleep already and who's talking to their neighbor. You don't have a sense of the audience here. So this gives us a pretty good distribution of those of us actually who take care of babies with transposition. It's a very nice distribution. For the nurses who are in the audience, it would be great to learn how we can increase the knowledge of these sessions to nurses throughout the world. So if anyone has any ideas, feel free to drop that in the survey at the end. Grace, are you going to have a survey at the end in terms of a course evaluation? Have you had that?
Yes, I will just type on the chat box the link, and everybody who attended is going to receive the link by email as well.
Okay, great. Thank you. Thanks. What do we have next? Where do you live? So it's 11-ish here on the East Coast of North America. So it's 5 o'clock in the morning there. Oh my gosh, there's people up at 11 o'clock at night in Asia. Thank you. No one has checked off Antarctica. I always get disappointed by that. Very good. Just a few more to answer that and we'll move on so we can talk about transposition. You can still fit it. It's anonymous. No one will know how old you are if you'd like to tell us. Most of our webinars have been between about 31 and 50 and then skewed off to the right. That's fairly typical. Paul, looks like there's one person out there in your age bracket. That's great that you have Paul's mic muted. It's much better from my perspective because he's going to give me a hard time. Okay, we're going to go into the next one. My gender is. And I don't know if I have any more for demographics. Oh, one last thing. Because this is the first time we're doing it and we have no idea how the interaction time is going to go, would you be willing to stay if we were to go out to about 90 minutes? Oh, that's good to know. Okay. I love all my friends and cynics on the right over there. Perfect. Very good. So we'll play this by ear, but we'll definitely finish by 12:30 Washington time. We'll try to do it a little bit earlier. Okay, so I'm going to stop this because we have some cases to discuss, and I'm now going to go on to the formal part, which this part's going to be actually very quickly. I wanted to sort of talk a little bit about my own background, just for some perspective, especially for the fellows. And we do a series here at Children's National with our fantastic fellows, which they call Deep Thoughts, where we sit around in the morning and we talk about how careers get to where they've gotten to. The very first paper that I wrote was on transposition back in '88. And it's great that I'm still working with my first mentor, Tom Haugen, on this. This is a picture of us back from those days when we warmed babies. Eve, take a look at this. These are warming lights after cardiac surgery and an EKG on a patient after an arterial switch operation. It might have been a baby with HLHS, I don't know. And then I was fortunate enough to have the opportunity to work with Jane Newberger, Richard Jonas, Aldo Castaneda, and others on a randomized clinical trial. So I was fortunate to be in the right place at the right time and listen to what my senior mentors told me to do. And I'm not going to talk a lot about the circulatory arrest study now. We will be talking about this at future webinars, but we enrolled 191 patients, of which 168 survived, and other than 65 minutes in the OR, the groups were identical, and that was their support strategy. I remember when Dr. Newberger showed me this study about the circulatory arrest study, and it said 2001, and I thought, I can't imagine a study going that long. And here we are now in 2020, where in fact the adult study is currently being conducted up in Boston. And amazingly, 67% of those patients still eligible from 1988 are still being followed in a clinical trial 30 years down the line. And a real tribute to the infrastructure up at Children's Hospital up in Boston. So I got involved in these types of things early on, a lot of manuscripts, a lot of smart people telling me again what to do, but very important things was the friends and colleagues that I made early on in my career. And that's what keeps you buoyed, at least me, that's what keeps me buoyed in this field, is to stay in touch with people in the field. And now that we have Zoom and now that we have all these other great ways of staying in touch, I think that we're going to be able to push the field forward faster. One of those persons is Richard Jonas. I'm not sure if he's on today. Richard just retired from clinical work. We had a great opportunity to follow many patients for a long period of time with transposition. And before I start with the case presentation, I want to talk about this baby named David, who was study patient number 3 in the Boston circulatory arrest study in 1987. And here's David with his baby 30 years later. And this is why we do what we do. We should never lose sight of this. We do this not to get ICU discharge or a statistic or even a research paper. We do what we do so that we can turn these babies who are very sick and these families who are very scared into productive, functional adults who are extremely grateful. And this is what's so wonderful about our job. And finally, I want to say with great thanks that Dr. Castaneda sent me away for a month to work with Milton Paul at the then, Paul, what was the name of Lurie right before? Children's Memorial Hospital. That's right. I worked with Milton at Children's Memorial, who did much of the early cath work on the physiology of transposition, which I'm going to share with you. Okay, so the introduction's done. The series is done. The goal of these lectures is to spread information, to challenge dogma, to stir the pot. If you're thinking you're going to come onto these webinars with what's the best medicine to use after this particular type of repair, I think you might be disappointed because of all the variability that we've learned. To broaden the perspective beyond our own individual units and to emphasize what we don't know as much as what we think we know. And Sasha showed me this before we started today, which is a quote that has stuck with me from early medical school days, where a professor said, "Half of what I'm teaching you is wrong. The challenge is I don't know what half it is." And we have to remain humble with that and to listen in our intensive care units and in our clinics and in our operating rooms. Last, these are the upcoming talks. If you have other ideas, I'd love to hear them. Next month, postoperative care in November. And I want to thank Tamara for the idea to talk about cognitive dissonance again and other ways that the human psyche prevents us from providing optimal care. We'll talk about fragility and resilience. Then I'm really going to stir the pot with the notion that the management paradigm, including physiology that we do for HLHS, is all wrong, that the Fontan pathway needs a lot of road work. We'll talk about critical care. We'll talk about single ventricle part 3, which is why do we call it pulmonary atresia intact septum instead of aortic atresia intact septum? Why do we have such different ways of thinking about hypoplastic right and hypoplastic left heart syndrome? And then we'll talk about tetralogy. All right, that's about the series. We did the audience, and now we're going to talk about physiology. You all know the anatomy, aorta to the right ventricle, PA to the left ventricle, and transposition physiology can be defined simplistically as when the pulmonary artery saturation is higher than the aortic saturation. The pulmonary and systemic circuits are in parallel rather than in series. And for these graphs, I'm going to do them rather than anatomically correct hearts. I'm going to show the boxes on your left as the right atrium and the right ventricle, the boxes on your right as the left atrium as the left ventricle. The caval return and pulmonary venous return is at the top. The pulmonary blood flow and systemic blood flow is at the bottom. You can see the labels there. There's our pulmonary veins. And we can see that the systemic venous return and pulmonary venous return are running in parallel. Over short periods of time, when there is, and this is the fundamental principle of mixing between the two circuits. Over any short period of time, the amount of blood that shunts from the left side, left ventricular or pink side to the right side has to be equal to the volume of blood that goes from the right side to the left side. Otherwise, one circuit would fill up and the other circuit would empty. And there's one example of that, which we will get to. And the mechanisms that control that over any short period of time are incompletely understood. But those volumes must be equal. But eventually, as pulmonary vascular resistance falls, you start to have pulmonary blood flow increasing at the expense of systemic flow. And babies then develop what would be symptomatic heart failure. That X-ray, I guess, does look like an egg on side with pulmonary vascular congestion. We see these babies with subcostal retractions, antychypnia, and inability to feed. These are things we're all familiar with, but in transposition, it's associated with hypoxemia. And this, again, is the work of Milton Paul, where the babies were catheterized at an average of about 2 to 2.5 months. And as you could see, up at the top, the majority of the systemic blood flow is the recirculated systemic venous return. The majority of the pulmonary blood flow is the recirculated pulmonary venous return. The intercirculatory mixing is exactly equal, and the ratio of pulmonary to systemic blood flow is in the range of about 2 to 1 in this one series. This is when babies were catheterized. Now, the calculations are fraught with all sorts of error. I don't know, Damien, if you want to make any comments on this. It's unusual that we do catheterizations for hemodynamics and transposition anymore, but is there anything you'd like to bring up?
Yeah, I agree, Gil. I mean, I think it's very difficult to do a standard hemodynamic assessment in a transposition patient. I think it's probably not necessary most of the time now anyway, because a lot of the time, you know, they're having an operation before really we need to do anything about them. So it's certainly not, I mean, the only time that these patients generally visit the lab now is if we need to do a septostomy. And that really is a procedure that is really focused on just opening up the atrial septum and nothing more. It certainly wouldn't be in our practice to do anything beyond that.
Yeah, this data may stay forever, right? It's unlikely we're going to get it through catheter. Thank you. We're going to talk about septostomy in a little bit, but again, for the trainees, when you think about, you know, the calculation of difference in flow between the pulmonary artery and pulmonary vein SAT, where we're talking about just a few percent, the potential error is quite wide, but it's of good historical significance. You always know somebody like me, Paul, that's getting close to the end of their career when they start saying, well, the historical data shows this. And I know you're going to get into that at some point, so I thought I would just jump in and interrupt you. I like to show this because I spent so much time on the damn PowerPoint slide, I have to find reasons to show it. So here's our parallel circulation of transposition, where we talk about the majority of the flow is the recirculated return of that circuit. But let's try to imagine what happens when you have a PFO, stretch PFO or an ASD. And we talked about the predominant amount of shunting in one direction equals the amount of shunting in the next direction. That's that. And now, I don't know how the frame rate is working for you for this. So we're going to talk about this particular baby, and we're going to try to come up with some consensus about what to do. So we've got a little baby here. There we go. Who has atrial mixing alone. So there's no volume load on one side or the other, at least initially. Baby doesn't have heart failure, is not tachypnic, but is hypoxemic. So let's say the pulse oximeter is now reading somewhere around 72%. The baby's happy and the staff is not happy. It's important to remind, especially the people that are not used to seeing congenital heart disease, that hypoxemia in the absence of respiratory distress does not necessarily need a machine to push the air in and out. But if you don't know the baby has transposition, it's quite common for physicians or nurses who see the baby with a saturation of 72% decide that they want to put a breathing tube in. But we're going to go to what do you think in this particular case. So we're going to go back to our poll. If I can get that up here. There we go. Oh, people already did this. So 3 kilogram boy, 8 hours old, postnatal diagnosis, 3 millimeter hole, oxygen saturation, 74%. What should be the next step? All right, people, give people a little more time. I will call on Dr. Kekia. This baby's in your unit, 8 hours old, just diagnosed.
He's getting a septostomy. In my unit, he'll get a septostomy.
That's the next thing.
That's the next thing.
The very next thing.
The very next thing. But I will tell you this, if you want to be challenging a little bit, which you said you wanted this, so watch out. I will go straight to the why bother with the dance of septostomy and prostaglandin. In today's world, why is the next step not to the operating room right now? Did I go too far, Gil?
No, that's actually coming up later, so thank you. No, that's fantastic.
It depends. What time is it? Night or day?
There you go. Thank you. Finally, an admission that it's really on our schedule, right? So your thing about the staff is not happy. Is the staff not happy because now we got to work a little bit differently than we were used to? But now I'll stop.
Now, what if I told you that the echo had a 2 millimeter ductus?
Gil, could I go in there? Would you consider a blood gas as the next potential investigation, certainly, that you could do? Sure.
The pH is 737, the PCO2 is 42, and the PO2 is 32.
And no lactate?
0.7. That's the random number generator that we get back from our laboratory anyway, so may as well just say that.
What's the NIRS?
The NIRS is the machine that's in the back and not on the baby yet, but we're going to get to that to the next one. But that is interesting because we're going to talk about the risks and benefits of septostomy in just a little bit, okay? And the risks and benefits of prostaglandin in just a little bit. But it is interesting, a third prostaglandin, roughly a third in this group. I would probably give the baby oxygen. But we'll see where we go with other things there. Okay. Well, so now you all said what your first thing would be, which would be a septomy. Paul, what would be your second thing?
If that doesn't work, then I would go ahead and start prostaglandin.
Interesting. So we're getting something like prostaglandin and septostomy in some order with the majority of the people that are here. Eve, would you consider taking an 8-hour-old, it's Friday morning at 4 o'clock in the morning. Would you consider taking this 8-hour baby to the OR now?
I never say no, but so I think I would consider to take the baby straight to the OR. I'll tell you what we have been doing in Melbourne, and it's surprising. You're going to get to the pulmonary hypertension issue, and and not good mixing. And I don't know what is what and what is causing what, but all guys were getting so excited about desaturation. It's a transposition baby, for God's sake, just relax. But they could not tolerate it. And so they asked for ECMO. And the way ECMO works in the majority of the unit is you call for ECMO, we put them on ECMO, and we talk later. So this baby is on ECMO, and then we do it the following morning. So that I've seen that practice, but I know that it's an unusual practice, and that's not something to recommend. You ask me, I rather bring the patient straight to theater. I think but you have to look at you have to look at your staff, and it's not a minor issue. So you have to see the timing and not wear down your resources. You don't have many cardiac surgery scrub nurses in the world. So
thank you, Yves. Sasha, how about in Taormina? What would you do there?
Yes, as I told you, generally we hate prostaglandin. So if generally we use as a first step balloon arterial septostomy, as a routine therapy. But if we have a rule, if we can maintain prostaglandin for 24 hours, but if for prostaglandin at the weaning, the patient start to desaturate, we prefer, I told you, to do switch.
Why do you dislike prostaglandin? It's a good drug. Lots of people have it and they survive it. So,
yeah. but as you say in TGA, I think that there is several reasons. Like we face patients with pulmonary hypertension, and sometimes when we force with the systemic flow, the pulmonary flow, after the operation, we have very unstable patient from pulmonary vasculature. So we prefer to do this in the first week of life.
Yeah, Yves, we're gonna get to all those questions in a bit with some good polls. So obviously we've hit on the right questions. Grace, I just wanted to ask your preference in these situations. Blue baby, regular daytime, not sick, but hypoxemic.
Sorry, I'm muted. If venous hearts are reasonable, NIRS are good, baby starting to pass urine, he's smiling and looking at me, nothing, only monitorization. And be ready for septostomy if needed.
Very good. Prostaglandin nearly always improves oxygen saturations when the ductus opens in transposition. Nearly always improves oxygen saturations. We have some skeptics here.
Okay.
It's changing. One of the fun thing with this new platform is to sort of see how things evolve. It worries me about the election, Paul, because what happens is the people on the West Coast look and see what happens in the East Coast, and it may change what they do. So
what you say also, because
we are not Paul. We are not going to talk about. We're not going to talk politics. I have to keep him now. Okay.
No, because yeah, this could go ugly really fast. So I'll stop.
So I'll change the question from prostaglandin nearly always improves oxygen saturation to prostaglandin nearly always improves oxygen delivery when the ductus opens in transposition. And I'll show you a couple of examples of that. It's so funny how we all have a dogmatic plan about what we would do, yet we're split across quarters about what it actually does. I think that that's a very interesting part about the dogma that we teach and that we learn. And Paul, you and I have talked about this ad nauseum, but we had a definite plan, but what it actually does may be very different. It'll be fun to see how this sort of moves forward. Okay. The mechanism of prostaglandin improving oxygen saturations is A, 2 sites of mixing rather than 1. B, increases pulmonary blood flow and pulmonary venous return. C, I don't have them on my screen right now.
I think it decreases oxygen consumption, what you said.
Oh, right. C was decreases oxygen consumption. D, I think, was magic, right? And E is A and B. And I hope when you see the next few slides you'll realize that at least in terms of the correct terminology, the correct answer here is B, not A and not E. At least what I think, which obviously means nothing. All right, so now we're going to go back to our slides. Thank you to the people who are, if people want to respond to the Q&A and the panelists, please do. I'm going to go back to our slides. We seem to be doing okay with time, Grace, is that okay?
Yep, you're good.
Okay. All right, so we did that one. Okay, so now we have opened up our prostaglandin and it's attached to the baby. And what happens is the ductus opens up at the bottom. And because pulmonary vascular resistance is less than systemic vascular resistance 99% of the time, you don't mix at the ductus. That's an incorrect term because the flow, even though by echo you may see, quote, bidirectional shunting, the overwhelming majority of it is from aorta to pulmonary artery. And this has been shown in old studies as well. And since we talked about the volume of blood flow in one direction has to be equal to the volume of blood flow in the next direction, we end up with a predominant aorta to pulmonary artery shunt at the bottom in the ductus and a predominant LA to RA shunt in the atrium. So the predominant mechanism by which prostaglandin improves oxygen saturation is improving the amount of pulmonary venous return there is, which brings additional oxygenated blood into the right ventricle and ascending aorta. And I'll show you some photos of that in just a second. So now we've got a baby that has an oxygen saturation that many people like. The oxygen saturation is quoted as better, but now the baby's got a volume load, right, from a ductus and may have symptoms of congestive heart failure. This is just one thing I pulled off a bedside monitor where opening up the PDA in transposition will increase the oxygen saturation here on the bottom. But as you might expect, a widening of the pulse pressure here and an increase in the heart rate to deal with the volume load. So you get a higher oxygen saturation, but at the expense of a wide pulse pressure, tachycardia, potentially the risk of neck and other problems. Okay. So here's one of the myths that I hear a lot on in the CICU, which is the baby's stable on a prostaglandin infusion. And that's why I love to hear Sasha at a recent webinar. He said, we don't like prostaglandin. If a baby's on prostaglandin, they need an operation. And if there's a reason not to do the operation, fine. But if they're on prostaglandin, it's surgical heart disease and it should be fixed. Because the reality is a baby on prostaglandin is in heart failure. Babies with structurally normal hearts and large ductuses get into heart failure. Preemies with large ductuses go into heart failure. They get necrotizing enterocolitis. They get low cerebral blood flow. So no baby is, quote, stable on prostaglandin. It's buying time. This is my opinion. I word it very strongly, but again, I think you have to take your own unit and what your own resources are to determine what to do with that. We've also heard that.
Can I interrupt you, Gil?
Yeah, you just started here, what, 2-3 weeks ago? You're interrupting. Excellent.
So we looked, because it's any theoretical consideration is worth it, but when you talk about timing of surgery, data is always best. And so we had a lot of publications on arterial switch. We had a lot of data. And we looked at the timing of surgery. And so whether we keep the baby between, about a week or whether we operate them within 48 hours. And actually the total time of hospital stay was the same. So whether we keep them on prostaglandin for a week or not, if you're doing the operation earlier, they ended up staying longer in the hospital. So I cannot say it's bad or worse, and it doesn't seem practically to make a lot of difference if you look at hospital stay and ICU stay.
Yeah, thanks, Eve. I think that's very worthwhile. I'll show a couple of other data that is consistent and inconsistent with that. And I'll show you one last piece about, unfortunately, the preoperative period, each day is worse for the brain. So if we look at mortality and length of stay, it may not make that much of a difference. But I'll leave it there, and we can talk again after we show those slides. We've talked about prostaglandin a bit. It's the open ductus that bothers me. It's definitely associated with PVL. It's definitely associated with necrotizing enterocolitis. Many surgeons have commented on tissue friability, which may just be increased water. Prostaglandin can lead to hypotension, apnea, and rash. And my experience has been that most of my colleagues don't like prostaglandin. They would prefer higher oxygen saturations rather than lower oxygen saturations. We do know that if PVR is low, and we're taking generalizations here, but if PVR is low, the diastolic runoff is particularly problematic. I'm going to jump ahead because we've been doing a bunch of things. I'm going to go to
Can I come in there?
Absolutely, Damien. I'm sorry. Anybody should just jump in.
I'm aware that we have hundreds and hundreds of participants around the world. Are your comments very much specific to TGA in that you don't like prostaglandin? Because I'd hate young fellows to be watching this and have a pulmonary atresia born at some point in time and say they were listening to something whereby they felt prostaglandin was bad and the baby didn't get started on prostaglandin. Can you contextualize that a little bit more? Because again, I'd just be conscious that we don't give a message to our younger generation of trainees coming through to suggest that prostaglandin is bad in all circumstances. Is that what you're saying, or?
No, it's not what I'm saying at all. And I appreciate you getting in the way of my own dogma, which I wish I didn't have. Partly is the English in there too. Prostaglandin is a life-saving drug. Let's not kid ourselves on that. The way I think about it is postponing surgery because a baby's not terribly sick with an open duct may not be the right thing to do. So prostaglandin is life-saving. And if you have, let's say you have pulmonary atresia and you need to get a shunt in there, you can stay on prostaglandin until you have to put the shunt in. And it's individualized. You're absolutely right. I appreciate it.
And just, to contextualize again, I have worked in North America. It's a fantastic place. I do think resources are a little bit more available than many other places in the world. The concept of being able to rush a patient to surgery at any point in time is just not a practical solution for many other places around the world. Sometimes we only have one operating theater. We're a country of 6.5 million people with the Northern Irish contingent as well. And it's a bit difficult resource-wise to say that we'll be able to operate at any time, on a baby like this. What are your thoughts on that? I mean, I think, do you think that, how should we manage the resource limitation issue in the context of a transposition worldwide, again, for people who are listening all over the place?
So
what do
can
I think? First, let me just say to Damien, thank you very much. One of the wonderful reasons to have people on from all over is to have that different point of view. And I said probably too quickly that this all has to be contextualized within your own unit, but it's good for me to remember that. And I really do appreciate that. Paul.
So first of all, a couple of things. One, I think what I'm taking from this message and enjoying it is the idea that just nothing is free, right? That unfortunately we've gotten so used to prostaglandin that we look at it as a free drug, a free utility drug. And Jamie, I completely agree that as long as it is put into context of this is what we're aiming for a resource management, not just, oh, we can put them on prostaglandin and leave them and it's free. That's the other. But then the final thing, when you talk about developing countries as well, we studied Texas as a state, which many people could say is a developing country. And it turns out that only 50% of the hospitals in the state of Texas that deliver babies actually stock prostaglandin in their hospital. 50%, because it expires, it's expensive, you have to keep it on the shelf. And yet when we examine the outcome of those kids, it doesn't matter. But that's because we have a robust transport system to get the kids to the heart centers that they need. So I find it very intriguing that prostaglandin is seen as something that everybody has. Surgery is a resource limitation. I wonder how often it's actually the reverse, that prostaglandin is the limited resource in some places.
Thank you both. I'm going to jump over to our our poll here. If I can pull that back up. My little screen doesn't allow me to push these things around. Okay, so let's take, we have a 6-day-old that presented with transposition intact ventricular septum, a restrictive PFO, and a balloon atrial septostomy, who 2 days after the balloon septostomy develops necrotizing enterocolitis. The team stopped the prostaglandin. The baby is ventilated on 30% oxygen, and the SATs are now 74%. What would you do next? This is now 4 days into necrotizing enterocolitis on antibiotics. We've got about 30 of you. I'll wait a little while to go on here. Sasha, why don't I have a comment from you about this case right now?
Oh,
what would you do at this point? Or Yves, Yves is waving his hand.
Yes, I agree with Yves, but my question to all of you from the ICU, why a patient needs a prostaglandin and another patient with the same disease doesn't need? Because this is probably the main answer where we have to go. Because for us, it means we are trained mostly in France, in Paris. Prostaglandin is not usual medical therapy for transposition. And probably the Ruskin, the balloon septostomy, represents the one. The prostaglandin comes when the patient doesn't answer or is a very poor answer to balloon septostomy. So we learned this, that after balloon septostomy and starting prostaglandin must be some pathological mechanism who is asking prostaglandin. Because generally, mostly of the transposition, as I agree with Paul, because we are using to visit our different country, and transposition they don't have prostaglandin. Probably it's a natural selection, but at the same time, I don't really believe if prostaglandin is a therapy for the medical doctor rather than for the patient. This is my question, my point of view. But this patient in our unit receive a normal switch operation. I don't want to say something.
Even 4 days into necrotizing enterocolitis?
No, it means it doesn't arrive at this point. Because it was already, this is the reason why we don't want to start prostaglandin. We don't want to maintain. It's something that is a bridge. It's not a medical therapy. It's a bridge, it's a message probably from the patient, from the physiopathological circulation state, that the patient doesn't have an adequate missing. You remember we told you the best place where mix the blood is the atrial septal defect, is not the PDA, is not the VSD. So if after atrial septostomy the patient is not stable, of course we can, as you say, increase only saturation because heart rate come up, blood pressure come down. So we are going to neck, cerebral hypoperfusion. We lose one patient for cerebral hypoperfusion with the continuous infusion of prostaglandin in transposition. This is something that we learned from 10 years ago. So we don't like prostaglandin because it's such a medical therapy that treat the medical doctor rather than the patient. This is our experience.
Yeah, there's a lot of times people say the baby required prostaglandin. We have no idea if they required it. All we know is he received prostaglandin. And I think it's true. Milton Paul, who taught me about a lot of this stuff in the days before neonatal sendings, was very clear to say, hey, the baby can go home with a saturation of 60 and you come back later. But it makes us nervous in our current environment. Yves, you were going to say something.
Yeah, a few things. It's true that at the time of GOS, we were told not to look at the saturation, discharge the baby home and do it a week or two later. And that was the current practice. And it was said, please don't look at the SAT. And the other thing is that we I don't know. I've seen not feeding babies who are on prostaglandin because the combination of feeding and prostaglandin may be toxic. I don't know if that's true or not. The other thing I would say is that I'm not scared of a surgery, generally speaking, but the patient is on neck, it doesn't get surgery. I never operate on patient with neck. They get, you cannot do bypass on this case. They open all the microcirculation. I think it's very difficult to get any survivors if you do an operation in the middle of the neck. Paul and Damien, and what do you think? You operate patient with neck?
Yeah, to me, this is the thing to avoid at all costs, right? Because, like you said, it takes away the opportunity. You know, and to unpack a couple of other things you said, again, I agree with you completely to not look at the saturations, right? To look at what's going on, but then you can see the dance that we do, and we actually shoot ourselves in our own foot, because now they're on prostaglandin, so now we can't let them eat. Now we obsess about the saturations. Now we start getting blood gases Q1 hour and lactates continuously. And next thing you know, they get a bloodstream infection. So now they're septic and they have neck, and now we can't go to the operating room. When if you either go to the operating room or you have the septostomy, you put a bottle in their mouth or a breast, and if they want to eat, they eat. If they don't, they won't, and that's that. And then you take them to the operating room.
I think, just to come in, I think one of the difficulties we have is that not every baby with, in fact, no babies with transposition are born in our hospital. We're not a neonatal hospital. We are a children's hospital, a standalone children's hospital. And sometimes you'll get a call at a specific time that's sometimes outside working hours with a baby who is postnatal diagnosis suspected of transposition, and you don't know what the diagnosis is, and the saturations are, let's say, 70%, and you're talking about transporting that baby in an ambulance for 4 or 5 hours. It takes a brave person to say, don't put that person or that baby on prostaglandin before you have a diagnosis. Where I see neck with these patients is that then they're transported, either tubed or not tubed. During the transport, their saturations dip a little bit further. The prostaglandin, and prostaglandin is not binary. 3 nanograms per kilogram per minute for me of prostaglandin is very different to 50 nanograms per kilogram per minute of prostaglandin. And by the time they get to us, sometimes they're on industrial doses of prostaglandin. You take to the lab, you septostomize them, and you know that duct becomes a different beast once you have an open atrial communication then, and you have the problem of real steel, diastolic steel from gut flow, and that's when they tend to get neck. So all of these things are preventable to some extent. I don't think always prostaglandin is the villain in it. It's certainly contributing, but I think we tend to be the villain because, going back what you said, Paul, we've kind of over-treated this patient.
And there's another
go ahead, Grace.
Just sometimes, or most of the times, in some centers, even when you have a successful atroseptostomy, people don't want to stop prostaglandin. And just to let you all know, guys, Dr. Z just joined in.
Thanks,
Thank
Z.
you, great. Thanks a lot. Hi, guys. How's everyone?
Hey, Z, we say septostomy and you appear. I love it. It's great. We're going to get to a couple of spots about that. I had no idea there was going to be this much excellent discussion, so I'm going to just push. Okay, one other question. This is on the other side of this. 30-hour-old infant, transposition, intact ventricular septum, basically a stretched patent foramen ovale. Somebody put the patient on prostaglandin. I have no idea who, Paul, but somebody did. And now this 30-hour-old infant has a saturation of 92, a wide pulse pressure, tachypnic and tachycardic. What do you want to do?
You know, this is Ziegel. I personally, in this case, I would stop the prostaglandin and watch the saturation and go from there. So if the sats remain above, I would say 80%, 85% with no acidosis, I think, you know, we can just wait for the surgery to be scheduled electively within the next, you know, couple of days. However, if the sats drop less than 80% or the patient becomes acidotic, then probably there's, you know, either you take this to the cath lab and open up the PFO/ASD. If the surgeon says, well, I'd like to wait for a few more days. If the surgeon is ready, then probably you can take this kid to the OR and do the operation.
I figured there'd be a number of these quite interesting. Just, I wonder how different this would have been answered at the beginning of this hour, because it's been a really fantastic question about the pros and cons of an open ductus. A, it's prostaglandin, and B, it's the physiology of an open ductus, which are co-linked variables. I'm curious, that our two surgeons, what would you do of these 5 options? Sasha?
Yes, probably Eve left already. No, it seems something that we build together, because as I told you, we will do as basic also in TGA ventricular septal defect septostomy. Because generally the patient born in our hospital, and after 3, 4, 6 hours they receive septostomy. So prostaglandin is something that we, as I told you, doesn't add as a basic medical therapy.
So you'd be in the green bar.
Yes.
The green bar on the script. Okay.
Yes.
Eve, I think, just went to do a truncus with interrupted arch. I apologize for. Okay, so I'm going to ask same question, but it's Friday at 4 o'clock. I was channeling my Paul Kekia. Let's see how close this is to the last one. Now, Friday at 4 o'clock in Taormina, I've been there, is at the beginning of the most beautiful sunset you could possibly have. Some charcuterie over the setting sun and some wine, and it's amazing. So I would imagine that medical therapy over cath or surgical therapy would be what the Taormina group would do.
Yes, for sure. Wow.
It is such a spectacularly beautiful place.
Yes. This is the reason because we don't use prostaglandin. No surprise in the weekend.
So this is interesting. Look at this graph. This is the question when I asked it last time, which is prostaglandin and septostomy. But now it's Friday night. Oh, let's go. All right. That's the fun part of these rounds. I get to play around with the way the questions get asked. Oh, here's a fun thing to do before we move into the postoperative period. Just to put down a couple words why you like taking care of kids with heart disease. Do this on, it's ahaslides.com/TGA CHA. Doesn't look like any other words are coming up here. Here we go.
Che c'è? Ah, vedi, ci sta spaccando, hanno detto sabato pomeriggio.
Grace, this is almost exactly what we see in every one of these webinars, with rewarding and challenging being the most common words that we see.
This is very interesting. Doesn't matter which audience do we have, our specialty always brings these words. This is beautiful.
Yeah, it's nice. I don't think I've seen money yet.
If they could find money here, please let me know. I need that too.
How many surgeons are in the audience?
All right, Paul, I'm going to continue. What's the ideal age to operate on TGA, intact ventricular septum? And this was getting toward what Eve was talking about before. And we will go till 12:30. Hopefully we'll be able to get through some of this. So there's a consensus of 3 to 5 days of the people who've gone here. 1 or 2 people in the first 24 hours of life, but mostly in the middle of the first week, 6 to 7 days out there on the right. And again, some of this is, and I'm really glad Damien brought this up at the beginning, because what's available in Washington may be different than Dublin and very different in Abu Dhabi, I guess. I don't know, but we will learn. So let's see what's the difference between what's the ideal time and what is it at your institution. When do we usually operate on TGA, intact ventricular septum, at my institution? If you know. If you don't know, that's cool. So I get the sense, I'm going to go back to that other slide, that the ideal time is earlier than the reality time that we're seeing on this slide. All right, so this was the last time, and that's where we are now. Interesting. Okay, I'm going to get to that in just a second. I'm going to go back to a few slides for about 10 minutes. Oh, I just wanted to show some interesting data from a patient that was that patient that we were talking about before. So we did an echo on this patient. Prostaglandin was ordered and it was started here. So this was that baby with the necrotizing enterocolitis, and SATs were actually down in the 60s and then bumped up to 93. But as we've talked about before, you can see pretty quickly that not only did the SAT go up, but the heart rate went up. The pulse pressure widened from about 26 to 39. These are all the things you'd expect to see with opening up a ductus. But what was interesting, this is one patient, but it was interesting to me that in this baby, we had a near infrared spectrometer on the forehead, and the near infrared spectroscopy suggesting oxygen delivery to the brain went up by 15%, despite what looked like a widening pulse pressure and increased heart rate. However, the abdominal nears went down 20% in this baby with necrotizing enterocolitis. It's one patient. I'd love to start seeing the stuff in a series where we open up a duct in this disease. But it's interesting how the effects of prostaglandin are variable depending on the organ bed that you're looking at. And we have to keep this in mind, and why we talk about when is the timing of the arterial switch operation. Now I'll show this. Z, you didn't see the slides I was showing earlier for this, but we could spend a fair amount of time on this. But this is the one situation where these babies cannot be managed medically at all. And that's when they have an intact atrial septum. And we have a situation where there's basically no LA outlet. So we initially get a shunt from aorta to pulmonary artery at the bottom that returns. And we end up with a lot of pulmonary venous return that has nowhere to go. And we end up with that baby with profound pulmonary edema, and only, this can only be managed by ECMO or hopefully septostomy, urgent septostomy. Do you want to say anything technically about that, Damien or Z, in these few patients? And there's still, by the way, in the not prenatally diagnosed transposition population, about a 4% mortality because of this subgroup of patients. Z or Damien, any comments?
Yeah, this is similar to the babies with the hypoplastic left heart and intact or very restrictive atrial septum. So if you don't do something for them right away at birth, some people that may advocate prenatal, their outcome is not good. So you've got to rush them to the cath lab or bedside and do septostomy.
Yeah, I'd agree, Gil. And again, in a different environment, none of the children are born here, even when they're identified antenatally. So what we tend to do is we'll identify the fact that they're due to be delivered. We'll try and deliver them at a convenient time. We'll hold the lab. Normally it takes about 30, 40 minutes to get them over into the lab, get access, and try and septostomize them. So, we've done it within 45 minutes, which is not bad, but it's the only thing that you can do, and no delay, no UVC in, none of this messing around. Get the patient out into your lab as soon as you can. And that, those minutes actually make a difference. Because it's easy to start faffing around when you've got SATs of 40% and people are doing more gases and they decide to intubate the baby. No. There's one therapy this baby needs, and you need to deliver it ASAP.
Thank you. Paul is nodding. I think there's a consensus on that. I'm trying to remember what I put here. That's you. I guess most of us do this in the ICU these times, but it could be done in the cath lab. That's very unit and importantly catheterizer specific. Just like you're saying, there's only one therapy that can save this baby, and it should, in my view, it should be done where that cath attending where she or he can do it most comfortably and most effectively.
Gil, can I just come in there again, just on this specific point?
Please.
There are two types of septostomy catheter that most of us have used. There's an Edwards septostomy catheter, and then there's the Z5 that Z was involved with, that's made by NewMed. You know, there are variances and differences with those particular types of catheter. Edwards, unfortunately, have taken their septostomy catheter off the market because of concerns regarding distal fragmentation of a balloon following a septostomy, and they felt that, you know, that wasn't something they wanted to expose themselves to. The Z5 balloon, which is a lovely and a firmer balloon, goes over a wire. It can be a little bit more technically challenging to deliver a catheter into the left atrium, put a wire, and then put the septostomy catheter over it. That sometimes requires fluoroscopy to use it. So again, when you're making decisions about septostomy and where you do it now, we've moved away from bedside to the lab because of availability of catheters, with the Z5 or Z5 being the one that's more available, but it does make it a bit more tricky to do bedside. I don't know what you think about that, Z.
I agree, Dim, and I think, you know, at least, you know, for most of the old-fashioned interventionists, we love the cath lab environment. We feel comfortable. You see everything. With 2D echo, it's pretty hard. You know, we all know it's very hard to tell where you are exactly in the heart, although the echo can show you the balloon and everything, but exact, you know, relationship to vital structures is difficult to judge. And the point that you mentioned about the catheter over a wire, that is more of a reason also to do it under fluoroscopic guidance.
Maybe at the next PICS meeting. Do you have a date yet for the next PICS meeting?
Yes, September 2nd to 5, 2021 at Aria in Las Vegas.
Oh, great. I'm glad you were able to get that on. For everybody who's interested in catheter, it's just a fantastic meeting. Maybe you can poll the audience about cath lab or ICU and do a 2x2 table versus their age. Because I like how you say that.
Yes, yep, definitely.
All right, that'll be fun. And I wish you a lot of luck for that meeting, Z. That's fantastic.
Thanks a lot. I hope it will be a physical meeting rather than virtual.
We'll talk just a little bit about the brain versus the heart for septostomy. This is a big controversy. Personally, I think it's a tough call, and I'll give you my own view, and then I'm going to turn this over to the other people on the panel. It's probably 50-50 in the literature about the relationship of septostomy to stroke. And I think my own view is we don't ask the question the right way. I don't know if this works. Yeah, I tried to see if I could get these to sync, but what's in the literature is about that the septostomy causes a risk of stroke, and babies with transposition are the most studied group of babies, along with hypoplastic left heart syndrome, as to whether they have preoperative MRI abnormalities. And people have then looked at whether septostomy is part of the risk. But as I talked about before, you know, a lot of what is circulated out to the body is recirculated systemic venous return. And when these catheters are removed, fortunately, the bleeding stops with a thrombus. I don't know, I'm curious what people think, whether it's the procedure itself or the fact that there's a large catheter in the vein of a baby with transposition that's related to these problems. Because the other problem with babies with right to left shunts, and I wasn't sure if Eve was going to get back on, but in every baby we have with a right to left shunt, whether they have transposition or something else, they run the risk of paradoxical embolus. And that could be from their catheters, from their IV tubing, whatever it might be, little bubbles such as this one. The nurses do a fantastic job of getting them. We use filters, but we never can get all of them. And I say it a lot in our unit. Anybody with a right to left shunt has the potential to go vein to brain, whether it's a peripheral IV or a septostomy catheter. It's interesting that when we look at pre and post MRIs of transpositions versus hypoplasts, transpositions do not increase their risk of stroke 12 to 14 days later, whereas hypoplasts do, and they both get bypass. And my own opinion on it is much of this problem is in the intensive care unit and right to left shunting as a risk to the brain. So I put this up there, Z, because it's one of my favorite pictures of you, and I knew you would have a comment on stroke And I didn't know that the new catheter was called the Z-Med, so there you go. But I'm curious what the panel thinks about the risk of septostomy, and should we be doing that in babies with transposition that aren't dying?
Well, this question has been plaguing us for a long time, Gil, as you know, because some people, accused the procedure of predisposing these patients to stroke. I've been fortunate enough, in my career, honestly, and I've done, a lot of septostomies. I have not had a baby that had a clinical stroke. Now, if we did scanning MRIs on everyone, I don't know whether we will find somebody or not. But at Sidra, currently, every neonate with the TGA, and actually every neonate with congenital heart disease, we're doing MRIs on them before we do any intervention, just to look at this particular question and other questions. So the short answer to your question, I personally do not think it is a procedure specific. I think some of these kids, they may have abnormality in their brain, as well as possibly the intravenous fluids that we connect with them, maybe air embolism or something. But I don't know the answer, to be honest with you.
Mm-hmm.
I agree with what you said, Gil. What you're describing is, I think, the issue of all of these kind of questions that we stop looking at some level, right? That so technically, I agree with you that it's the clot, so it's the procedure, definitely, but it's not the actual procedure, it's the intervention. And I think what Damien said, this, everybody gets all hot and bothered, we start getting sloppy, we spend more time. I mean, the best place for a baby with any form of congenital heart disease is not in our clutches, right? It's to fix it and move on. And this is an overlooked opportunity for us to do more damage in the idea of doing well. And so it just has to be balanced. Like I said earlier, just nothing is free, not even a central line. It's not free. So just as long as we remember that, maybe we can start asking the questions differently like you just did.
All right, I'll run through a few more slides and then we'll have a chance to, if I can find them here, we'll have a chance to poll the audience on a couple more things before we go get ourselves some lunch here on the East Coast. I don't know. Okay, so take home message pre-op, and this is the way I think about these babies, which is, I think, crystallizing what a lot of everybody else has said, is that our goal is to get pulmonary venous blood to the coronaries and the brain. We can temporize things with septostomies and we can temporize things with prostaglandin, and those are excellent strategies. You don't mix at the PDA. I hope people understand that, because even if you get red blood going from the PA down the descending aorta, it doesn't get oxygenated blood to the head and coronaries. So I've really changed my thought process on the management sort of focus here is, can I get red blood to the brain and the coronaries at minimal risk? And then I balance what that minimal risk is. Is that prostaglandin? Is that a ventilator? Is that a septostomy? Or is that surgery? And the treatment for me is working with the surgeons and balancing risk benefit of all of these different interventions. The arterial switch is good. This is surgical heart disease, as my good colleague, John Berger likes to say. It's one of his Bergerisms, which is thou shalt not treat surgical heart disease with medicines. And it's a great expression. Blue brain, pink brain. Okay, I'm going to ask a couple of pre-op questions, or about post-operative questions. All right. And then I think we'll be able to sort of wrap up. Okay, can people see elective delay? Is delayed sternal closure coming up, guys, gals?
Yes.
Yes, okay, good. I've seen this now in a few different institutions. And again, I'm not talking about a baby who's bleeding or a baby who might go on ECMO that night, but a baby that, well, we just did a switch, we should leave the chest open. And the data to support this, there's anecdotal data, but the data to support this, I I am not aware of. But we get about a third never, a sixth always, and then 2/3 and 1/3. At my institution, we use peritoneal dialysis catheters after the arterial switch operation. Certainly in Melbourne technique, Roger, me and others put forward. I know the Cleveland Clinic has done much of this, but these are very institutional specific. Now that Dr. Dudicam has started working with us at Children's National, I'm curious to see how that might or might not change. Paul, what do you do in Houston?
Everybody, they get one.
They get one.
Yep.
Okay. And Grace, what about in Doha? Or Sasha?
Sorry. In Doha, we do PD catheter for all the switches.
How about Taormina or Dublin?
Yes, we use for mostly of the patient. We cannot say 100%, but mostly of the case.
Essentially always, right? In the pink. Okay.
Still, interestingly, we put them in, but we don't use them very often. Often they're just left on free drainage. So it's an interesting thing. Everyone feels more comfortable having them there, but I can't remember the last time on a switch patient we used a peritoneal dialysis catheter.
Oh, good. Well, I'm good. That's a good introduction to one of the slides I'm going to show. But it's interesting when I see this kind of variability in answers. Paul, we've talked about this so many times. When there's this much variability, there's got to be more data collected. But when you see that much in essentially always and essentially never, they're so diametrically opposed, right? So it's a good area for us to look for. At my institution, I don't know if Dr. Name is still on. I saw that she was registered, who's really been one of the leaders in EEG monitoring after the arterial switch. I hope you're there, Marianne, but wonderful work that you've done in talking about this. And I'll show you a slide about this as well, where it doesn't look like we're going to get to the follow-up today because of some wonderful discussions. And maybe we can, I can put the slides on the site for the late follow-up of the switch because I don't want to go too long and it's already 12:20. All right, so not a lot of in the middle stuff, right? It's either part of your protocol or not part of your protocol, which looks like it's about a 5-to-1 ratio. Okay, and then early extubation. So when do we aim to extubate babies after the arterial switch operation? When do we aim to? What do we try to? I find that interesting with such a large incidence of elective delayed sternal closure. Maybe I should have been more specific on when the chest gets closed, but. All right, so we've got generally half the people within the first 60% of the people within the first 36 hours. But what actually happens? When do we actually extubate the babies in my unit after the arterial switch operation?
Table.
Grace, are you still on? I can't see while I'm sharing the poll. We had.
I'm here.
Yeah, thank you. We have some suggested readings or a course syllabus that we're going to share.
I will place on the chat box and then I'm going to send by email as well.
Very good. So the slides, the papers that are being referenced in this talk, we have attached the links to so that you can download those papers at your leisure to look at some of the things if you're more interested after our discussions today.
We have a great news from Dubai. There is one colleague that say that they extubate on the table in Dubai. Probably you have to add to the.
I'll have to add a new manuscript. That's right.
Yeah.
I think I have some things to share there. Oh, that's not what I want. Please hold. All right, timing of surgery. We talked about this. In general, you could think about most operations go in this direction. In my view, you start to hit an asymptote when the risk starts to get higher than the benefit of waiting. And I'll show you some data for that. We've talked about this. I have to close this on my screen. I apologize. So this is an interesting group. I refer to this frequently. Dr. Yemetz and his colleagues in Kiev have done this, and no, Lviv, excuse me. Lviv or Kiev, I'm not sure. I apologize, in the Ukraine. And there's now a couple of groups doing Rashkin's, doing arterial switches with umbilical cord blood. And if you're interested in this, it's fascinating, fascinating stuff that definitely shows non-inferiority of doing this operation in the first day. So get the cord blood, prime the pump, bring the baby to the operating room, do the switch, and have the baby back in the OR before the mom is recovered from the cesarean section. I think it's fascinating stuff. And if you're interested, I've sent this paper. This is the 5-year experience from Dr. Yemetz's group, which is just fantastic information. I think we can say now that in the absence of complicating factors, the current data suggests that the optimal time for transposition is in 3 to 5 days. These papers are all available for you to review. Again, this is within the construct of the medical system that they're written. And I'm going to remember that every time, Damien, because it's particularly important for me that this is an international audience that has different availabilities of staff, et cetera. So that's the group from Columbia that Brett Anderson talked about. And then here's another paper from the group at Milwaukee, which had the same findings that doing this operation early on is better for your brain. So these are the 3 most common things or 3 most important things I think about as an intensivist when the baby comes up, which is hemostasis. Because if there's a coronary problem, they're usually having to fix that down in the operating room. It's uncommon that a baby comes up with good ventricular function and then has a coronary problem late, at least in my own experience. It does happen, but bleeding is the most important issue. Following that, it's the assessment of coronary perfusion. And as I mentioned, most typically a problem in the operating room will show up as an inability to wean from bypass. However, if in the unit you have early postoperative ventricular arrhythmias or poor ventricular function, especially regional, you have to have a very high index of suspicion of a coronary problem and generally bring that kid back to the cath lab. I don't find echo particularly helpful in this regard. A lot has been studied on these kids in the first night after surgery. We know that troponin release is highest in the first 4 to 24 hours. It's a little bit higher, as you can see, in transposition VSD. Again, all of these papers are there if you're interested in them. Complement increases in the first 24 hours. Respiratory function is worst, especially if there's non-hemofiltration of any kind used on the circuit. This is a project that I was fortunate enough to do just starting as a fellow and junior faculty member a long time ago that looked at the first 6 to 18 hours. I don't know, Paul, if you know the story here, but you see how there's no time point at 15 and 21 hours here. And basically, since I had to do the cardiac outputs in the middle of the night, the original plan didn't have them for every 3 hours. I wish that I had done them that way. We know SVR and pulmonary vascular resistance go up. I'm sure I'm reviewing things that most of the people in the group already know about. In the Primacorp study, which was about 1/3 transpositions in the neonates, we found exactly the same fall in mixed venous oxygen saturation here at 4 to 12 hours. That was a bit attenuated by milrinone at the time. If we looked at arrhythmias in an intensive care unit, I think I saw Amy Jennings was registered for this. I hope she's still listening. Major part of this study. And when we looked at what was seen after the arterial switch operation, it wasn't uncommon for us to see non-sustained VT or SVT in this group of patients. It's a small group here, but Larry Rhodes looked at a much larger group. And it's important to point out that ventricular ectopy is actually common. So this is a challenge when we're looking at babies early post-op who are looking well, but having ventricular ectopy. And you have to make a decision. Is there ventricular ectopy because it's the 10% that gets couplets or frequent PVCs, or is there a problem with the coronary? And in my view, the most important question to ask is to talk with the surgeon, as to have an honest discussion. Are you happy with that coronary anastomosis? Is there something we should take a picture with when you're in this situation? Paul, any comments on that as I move to the?
Yeah, I was waiting for an opportunity. Two questions. One, the obsession with ST changes, and I'd love to hear everybody's thoughts, because that causes more angst to the bedside nurse and the fellows in the post-switch time frame. And I've yet to find a surgeon who really cares all that much, right? I mean, obviously they care, but just plain ST changes. And then second is the obsession that some surgeons that I've worked with and still work with have of utilization of nitroglycerin in the post-operative switch. So I'd love to open that up to the panel and hear their thoughts on both of those.
I can't ask you a question and then get two questions back.
Yeah, that's the way this works. Unless the question is who's paying this bill, and then there's no discussion.
I'll do the EKG stuff first. I think the ST segments have limited predictive validity myself. You still should look at them, right? They just manipulated the coronaries. Frequently a conal branch is sacrificed so that you might end up with a nasty looking EKG and a perfectly fine heart, or a new bundle branch. Chest tubes can lie on the top of the heart. You should look at them and follow them serially, but in isolation, I personally ignore them. In isolation, doesn't mean I don't look at them, but in isolation. And then again, one of those great ideas that makes sense. I have no idea about coronary reactivity in a neonate, let alone coronary reactivity in a neonate with a coronary button, let alone coronary reactivity with a neonatal button and a denervated aorta. So it may work, it may not. I don't know if it hurts or helps. That's my short answer to a complicated question. Grace, what do you see with, we have one surgeon against 5 cardiologists, Sasha. So I'll ask Grace next what she thinks.
No chance. No chance.
I know she's busy on service. She may have difficulties right now. Z or Damien, any comments?
Hi, Gil. No, I'm sorry, I missed it. I got a phone call in the middle of listening to you from Doha. I'm in San Diego, but I got a phone call from Doha. I had to answer that. I apologize.
Why am I not surprised? That's perfect, Z. I love it. All right, I'm going to just, this last question, because it's 12:30, and I really do appreciate people staying on, and there's still 380 people, and I really do like it. I just want to, these kind of things, as I was doing a little work on this, were very interesting to me about some things to think about in addition to the heart and the brain. Pulmonary hypertension, an interesting article here from the European group about the neonatal arterial switch operation that are important to look at when we did the circ arrest study. Interestingly enough, this is using PVR in dynes rather than in wood units, so you divide by 80. I had forgotten when we used to catheterize these babies at 1 year, which is what we did in the circulatory arrest study. The upper limit of PVR is about 240, maybe 320 dynes per second per centimeter to the fifth. So the fact that we had this many patients over here with elevated PVR has not been repeated because we've stopped catheterizing these people. And the mechanism, and I know one of the questions in the chat, has not been completely elucidated. There have been some relatively new speculations on premature partial closure of the ductus in the fetus, as well as the oxygenated blood in the pulmonary vasculature of the fetus, as well as the presence of bronchial collaterals. But the exact mechanism has not been completely worked out. These are the collaterals that we've talked about. Again, very important communication from your surgeon. How much pulmonary venous return did you have on bypass? because the duct is ligated and divided 100% of the time to do the Lecomte maneuver. So if there's pulmonary venous return, it's coming from collaterals. And if you have trouble weaning from the ventilator, it's something worth looking into. And this is a more recent review in 2018 that talks about, if you look for them actually, roughly 15% of patients who got catheterized got coil embolization after a switch. Damien, have you seen many of these that needed to be coiled after arterial switches?
No. And, you know, they do exist. But again, to come back to the septostomy thing, only do things if you need to do them. And I think, you know, I agree if somebody's stuck in a ventilator after a switch and you can't figure it out, it's worth searching for them. And then if they're big, they're probably clinically relevant. The chest x-ray suggests there's problems, etc. But again, we don't go looking for them very often, so we don't see them.
Yep.
Can I say something, Gil, about this? We have an idea that, you know, before the operation, generally the cardiologists, they saw some, they say there is some collateral, but the patient is not operated. After the operation, we saw that this collateral, will grow, will become very big. Because I think we can see them normally only after the correction. So sometimes it's very difficult to make a diagnosis and treat before. This is what we learned from our, of course, small experience. But Davide, 2 weeks, 3 weeks ago, he experienced one switch, not in Italy, and he got this problem, but post-operatively was perfect, was extubated, and then the collateral started to work. So this is something.
I'm glad you said that. I'm glad you said it, Sasha. This paper that we wrote a while back was done in a day where most of our babies got a preoperative catheterization. This is in the 80s, to look at their coronary artery anatomy. So we had a large number of patients that had preoperative angiograms. And if you look down there in the bottom, number 3, it's exactly as Davide was just talking about. We had a number of babies who we saw them preoperatively, and then when we cath them at a year, electively, they got quite big. But we balanced that with what Damien just said, right? Which is, if they're not causing a problem, do you go after them? And we won't solve that on this webinar, obviously, but I just want to put that in people's minds that if you're having trouble getting off a ventilator or a child's on a ton of diuretics and very tachypnic, this does happen after this operation. AKI, interestingly about the PD catheters in this particular paper, is surprisingly common if you use the definition, the rifle definitions of AKI. I've just been using creatinine in my practice for so long, but it may be that dialyzing these babies may shorten their postoperative course. I just don't know. The peak urea was certainly related to the length of ICU stay and duration of mechanical ventilation and staying in the PICU. So we asked this before, and I am actually at this point going to say we've gone very long, and I want to see if there's, I have to show this, Paul, because it's my favorite picture. Again, Paul's such a great friend, and on very short notice came on, and I want to thank Grace and Sasha, Damien and Z and Eve before for jumping in to do what's sort of a rounds. Paul, although he can be a cynical old bastard, is one of the most compassionate and intelligent intensivists that I've ever had a chance to call a friend and a partner, and I want to thank him. And as you can see, he looks just lovely in that pink shade. And Paul, what was the story behind this little girl that you painted your nails for?
Long-term pre-VAD heart failure patient waiting for transplant, got transplanted. Yeah, unfortunately, soon after this picture, succumbed, but she was awesome.
Oh, that's a lovely story. We'll never forget. This is why we do what we do. And by the way, that is a good shade for you, Paul.
Thanks. I
think you look
better
really,
better than the mock turtleneck thing in the other picture.
Well, there's everybody who's been on. This has been an experiment. I hope it's been fun. It certainly went longer than I thought. I had a whole bunch of stuff, and I can put them on the website as well. the follow-up slides about how often to follow these patients, what type of testing. And maybe we'll have another one, Grace and Sasha, on why the Lecomte maneuver should be abandoned, which is my new soapbox that I want to stand up on for the arterial.
I would suggest that we continue this one because we had 400 people and most of everybody is still here. And you have all of you guys have a lot of things to say. I would suggest, I know that we have a schedule so far, but maybe we can try to make a new session about TGA just to continue this one because this was amazing.
This was fun. I really do appreciate this. Sasha, you have a comment?
Yes, because we invite Lecomte for the next surgical.
Oh, perfect.
Don't ban him before he speaks in our surgery meeting, please.
Sorry for this, but
yeah, I should probably use a different word with that he should be abandoned. You know, I'll show you. This is what I think. Quite honestly, let me see if I can get this back up here. I was trying to figure out what to call the Lecomte maneuver. You know, so here's an echo with the Lecomte maneuver here. I wasn't sure if it was the saddleback maneuver or the tree hugger maneuver. But I think, and this will actually, that's a good idea, Grace and Sasha. Let's do a follow-up one where we talk about the problems in the pulmonary arteries and the coronaries and the neo-aortic root, because what's coming up now are challenges that are being seen 3 and 4 decades later. And as always with cardiac surgery, it's not until you see the challenges that you change the surgical approach. The switch has been the gold standard for 3 decades now. But with root dilation and everything else that we're seeing now, and the new option of a spiral switch, I've decided to now call it the nutcracker maneuver, as it sits there above the ascending aorta. When Eve is kind enough to join you, I promise you that I won't go that route. I was fortunate enough to have the opportunity to meet Eve at one point, and he basically changed this disease. I mean, he really did. So let's see if we can invite him to this particular follow-up, and I'll change some of the tenor of my slides.
Okay.
Great. Thank you, everyone.
Thank you, Gil. That was great. Thank you so
It
much.
was a lot of fun, everybody. Thanks.
Absolutely.
Thanks
Thank you
everybody
so
for
much.
attending, guys. Thank you
Yes.
very much. And please tell your colleagues that the next one is going to be as amazing as this one. And please share our video that is on YouTube to your colleagues as well. And invite your team. All the team is welcome.
Thank you.
Just looking at the shares.
Yes, Gil, we have from all over the world, people was amazing. Thanks to everybody, Nigeria, New Zealand, whatever you want. Compliments, was amazing. Thank you, Gil.
The Northlands of the United States. I somehow made it through without a single political reference, but I'm scheduled to do one of these, I think, on November 10th. The election is November 4th. And if it doesn't go one particular way, I may be doing the November 10th lecture from your house, Sasha. I will be in Taormina.
Yes, you are most welcome. Davide will cook, no problem.
No problem.
Excellent. Excellent. Davide, good to see you. Take care, everybody.
Bye.
Ciao, ciao.